A PTSD diagnosis can stem from a violent loss, a serious accident, or the repeated occupational exposure experienced by first responders and healthcare workers. This reality is frequently obscured by a narrow cultural focus that associates the condition exclusively with the battlefield. Data on PTSD prevalence reveals the scale of the condition across different populations. The baseline lifetime prevalence in the U.S. general population is roughly 6.8%. For combat veterans, that number is between 10 and 20%. For survivors of sexual assault, the rate climbs to roughly 50%. Within these statistics, women are diagnosed at twice the rate of men, illustrating a significant demographic skew. Navigating these various trauma profiles requires the application of the DSM-5 framework. These criteria provide a standardized method for identifying the specific symptoms that separate a clinical disorder from a temporary reaction to hardship. To maintain clinical accuracy, providers move beyond subjective self-diagnosis. They utilize validated psychometric tools, like the PCL-5, to establish a measurable baseline of severity before beginning any intervention. Using these structural frameworks to confirm a precise clinical diagnosis is the mandatory first step in determining an effective treatment pathway. The diagnostic gateway for PTSD requires direct or indirect exposure to actual or threatened death, serious injury, or sexual violence. Following exposure at day 0, the window between day 3 and 1 month is acute stress disorder. Many patients' symptoms resolve naturally before this mark. When symptoms persist beyond 1 month, it meets the criteria for post-traumatic stress disorder. A different clinical picture emerges from chronic, repeated interpersonal trauma over long periods. This is categorized as complex PTSD. Because the exposure is prolonged, complex PTSD includes additional symptoms, specifically severe emotion dysregulation and persistent disturbances in how a person views themselves. Both the time elapsed and the chronicity of the exposure are the factors that determine which diagnostic threshold a patient has crossed. A formal diagnosis is built on a 4-quadrant symptom model. The first of these is Cluster 1, intrusion. This cluster involves recurrent memories and dissociative flashbacks, identified by intense distress to trauma cues. To manage that distress, patients develop symptoms found in Cluster 2, avoidance. This includes internal avoidance, suppressing thoughts or feelings related to the event, and external avoidance, where a person evades the people, places, or situations that serve as reminders. As external avoidance becomes more persistent, it progressively shrinks the patient's functional world, interfering with their ability to maintain a normal daily routine. These two clusters create a cycle where internal triggers force continuous behavioral withdrawal. The diagnostic model also requires symptoms from Cluster 3, negative alterations in cognition and mood. This cluster is defined by cognitive distortions, like exaggerated negative beliefs about the world and distorted blame toward oneself or others for the event. It also includes an inability to experience positive emotions, leading to detachment. The final quadrant is Cluster 4, marked alterations in arousal and reactivity. This cluster manifests through physical symptoms like hypervigilance and an exaggerated startle response, along with chronic sleep disturbance, keeping the central nervous system in a state of high alert.
A PTSD diagnosis is only confirmed when a patient demonstrates active pathology across all 4 of these clusters simultaneously. This 4-quadrant structure dictates the need for targeted interventions. Because the disorder impacts cognition, behavior, and the nervous system, recovery depends on specific trauma-focused therapies. Cognitive processing therapy, or CPT, focuses on the cognition cluster. Over approximately 12 sessions, it helps patients resolve stuck points, the specific trauma-related beliefs that prevent them from moving forward. Trauma-focused cognitive behavioral therapy also utilizes a strong evidence base to address the relationship between a patient's thoughts, feelings, and behaviors following trauma. Prolonged exposure therapy addresses the avoidance cluster by guiding patients through imaginal exposure to the memory and in vivo exposure to real-world situations they have been evading.
Eye movement desensitization and reprocessing, or EMDR, is a widely used modality that helps the brain reprocess and integrate traumatic memory networks. Deploying these methods requires specialized clinical training and the use of structured tracking tools like the CAPS-5 to monitor symptom reduction. These therapies are effective because they are designed to dismantle the specific avoidance patterns and cognitive distortions identified in the diagnostic matrix. Pharmacotherapy is used to support, rather than replace, these psychotherapeutic interventions by helping to manage systemic symptoms. Frontline medications include SSRIs and SNRIs, which have moderate efficacy in stabilizing the emotional state. Sertraline and paroxetine are currently the two medications with direct FDA approval for PTSD. For specific symptoms within the arousal cluster, prazosin is often utilized to reduce the frequency and intensity of trauma-related nightmares. However, benzodiazepines are generally contraindicated for PTSD. These medications can worsen outcomes by interfering with the emotional processing that must occur during therapy, effectively preventing the patient from integrating the traumatic memory. Other options, such as MDMA-assisted therapy and ketamine, are currently under review, though they are supported by a more limited evidence base than traditional therapies. The goal of medication in PTSD is to facilitate psychological work. Using chemical agents to simply dampen the nervous system is counterproductive to long-term recovery. The pathway from exposure to recovery follows a sequential process: initial assessment, the application of targeted trauma therapy, and the continuous monitoring of symptom clusters. Managing this process requires a licensed clinician, such as a psychologist, LCSW, LPC, or psychiatrist, who can conduct structured interviews and apply validated measures. Telehealth has expanded access to these specialists. Practices like coping and healing counseling provide HIPAA-compliant trauma care across all 159 Georgia counties, offering remote access to EMDR and CPT-trained therapists. Comprehensive care also involves coordination with primary care physicians to monitor the physical health conditions that often co-occur with the disorder. If you are currently in crisis, the 988 Suicide and Crisis Lifeline provides immediate assistance via call or text. While PTSD involves a systemic disruption across 4 distinct symptom clusters, adherence to these evidence-based clinical pathways provides a documented, reliable